So, greetings everyone, and welcome to this interview with Dr. Vladimir Zelenko out of Monroe, New York. Greetings, Dr. Zelenko. We are very pleased to welcome
Hi,
Dr. We are very pleased to welcome Dr. Zelenko, who is a family physician, but is also a very well-known person since this COVID crisis. Given his role in developing a treatment protocol for COVID-19. The story is just a few months long, as you know, but I think it started substantially in terms of treatment on this part of the world. It was in March, as you remember. And on March 23rd, which was a very interesting date, you wrote a letter to medical professionals around the world. And you described your protocol based on hydroxychloroquine, azithromycin, and zinc. And you indicated how you were already successful on March 23rd at treating patients on an outpatient basis and in your community. And so my first question, has anything changed in terms of your protocol, your treatment protocol since?
No, not in the stage 1 of the viral infection. What I mean by that is that when patients present within the first 5 days of symptoms, my data shows, I just published a paper which is available for now on preprints.org while it's being peer reviewed. But so my data shows, together with, by the way, I did the research with two world famous medical researchers from Germany, Dr. Roland Derwent and Dr. Professor Martin Schultz. And they were phenomenal in helping me analyze the data and prepare a paper that should be accepted by the rest of the world, I hope. And so anyway, our data showed that if you use what's been coined the Zelenko protocol, which I'll describe in a minute, an 84% reduction in hospitalization and the overall survival of my patients of 99.3%. And so really nothing has changed. I still use zinc, hydroxychloroquine, and azithromycin, or sometimes I substitute with doxycycline, depending on the patient situation. However, I have modified my approach in the later stages of stage 1 or beginning of stage 2, where patients begin to have pulmonary complications. For those patients, I use high-dose steroids and anticoagulation to mitigate the inflammatory response as well as the risk of hypercoagulation and blood clots, strokes, and pulmonary infarcts.
There were findings, as you are fully aware, about the fact that there can be damages to the lungs even before the shortness of breath occurs, and so that may have had implications in terms of the timing of deciding the treatment for mildly symptomatic patients.
Right. So I've become much more aggressive in using steroids. However, overall, my team saw 2,200 patients with COVID-19 diagnosis in the outpatient setting since beginning of March. And we had 2 deaths, unfortunately, and one of the patients had advanced leukemia, and the other, he had CLL, and the other patient presented, he was really sick. He was in his 70s. So, but other than that, I've had excellent outcomes, and I don't really have patients that are having any lingering pulmonary complications, except those, unfortunately, that ended up in the hospital and were intubated or had some severe pneumonia or acute respiratory distress syndrome. Those patients have lingering pulmonary fibrosis, we're finding, and in those cases, steroids seem to have a role, maybe long-term steroids. But so far, I have not found a need for long-term steroid use in the mildly stage 1 patients. However, I haven't really done CAT scans on those patients to see the status of their lungs, and that's going to be my next project, to take patients that are post-COVID and are really asymptomatic, but to scan their lungs and see, what the status is at that point. It'll be an interesting study, actually.
Maybe we can build on this. As you know, there are various types of testing happening, but some take several days. So how do you deal? You will prescribe on the basis of symptoms. You are going to prescribe on the basis of tests. Having tests is great, but there is a timing issue.
Exactly, that's right, and that's that timing issue has led to hundreds of thousands of unnecessary deaths. Let me explain to you what I mean. On average, the statistics are that patients come to their primary care doctor's office between day 4 and 5, and I'll tell you why. On average, the first 2 days a person gets sick, they think it's a cold or whatever, and it's going to get better on its own. Around day 3, when they realize it's not getting better, they decide to call the doctor's office. And at least in America, most patients will get an appointment in a day or 2. That brings them to day 4 or 5. And why is that important? If you look at the viral load dynamics of COVID-19, so for the first 5 days with the onset of symptoms, the viral load, or the amount of viral concentration, is relatively constant. But around day 6, on average, it explodes like a wildfire and gets out of control. So that's when patients begin to get really sick. Now, think about it this way. If a patient comes to my office on day 5 and they have all the symptoms of COVID, by the way, it's pretty easy to diagnose COVID-19, and I'll explain to you even how to differentiate it from influenza virus, but it's relatively simple. A good clinician can use clinical judgment and sense, and with a pretty high accuracy, sensitivity, diagnose patients, probably even more sensitive than testing, and I'll explain in a minute. But nevertheless, at least at this point in the primary care setting, it takes 72 hours to get the results, which is pretty good, actually. So if I would do a test on day 5, on average, I'll get the results on day 8. Now, as I mentioned, by day 6, the patient's viral load is out of control. So it's like, I'll give you an analogy. Let's say someone has a fire and they call the fire department, and the fire department says to you, okay, we'll come in 3 days. Right. So what I've started to do, and that's, I think, one of the main reasons why I've had such good clinical outcomes, thank God, is the fact that I started to treat before confirmatory testing. In other words, I used my clinical judgment, my clinical sense, and if the patient had all the symptoms or I felt they had it, I would initiate treatment immediately. So let me describe to you in general what's been coined as the Zelenko protocol. It's not the 3 drugs. People right away think that I'm referring to that. There are 3 steps, but the first step is to cherry pick, risk stratify patients. Now, I don't treat everyone. I mentioned to you I had 2,200 patients. With my risk stratification criteria, I only treated with medication 800. The majority, 2/3 actually, were not treated with medication. Now, by the way, medical treatment doesn't always mean to give medication. Sometimes you have to know when not to cut, when not to intervene. So 2/3 of my patients fit low risk criteria, meaning they were less than the age of 60 with no comorbidities, and they were not toxic in my office. So those patients statistically have an extremely high rate of recovery without any medical intervention. So all I suggest for those patients is fluids, Tylenol for fever, and most important, close follow-up. If anything worsens, they should notify me immediately. But the majority of those patients, almost 100% I would even say, recover on their own. It's the high-risk patients, which I'll define as over the age of 60 with mild symptoms, under the age of 60 with mild symptoms and comorbidities, such as cancer, immunosuppression, heart disease, diabetes, hypertension, and so on. Those patients are high risk. And when I say high risk, I'm talking about, depending on which country you look at, between 5 to 10% mortality rate. As well as I also include anyone that looks toxic in my office. That's just a clinical sense, they look sick. So those patients are the ones that I treat with medication. Now, I treat them immediately, with, like I said, within the first 5 days of symptoms, or as soon as I can, as soon as they present. And I use the three-drug protocol of the most important is zinc, believe it or not, the mineral zinc. It's the drug that inhibits important enzyme called RNA-dependent RNA polymerase, or replicase. That's the enzyme found inside the cell, in the cytoplasm, that's involved in viral replication. And zinc inhibits the functioning of that enzyme. So essentially, zinc is the bullet that prevents the virus from growing or kills the virus. Indirectly, actually, because what it does is by weakening the viral load, lowering the viral load, the patient's immune system can actually clear the virus. So it's like weakening the enemy. The problem with zinc, it doesn't get into the cell because it's an ion. It's in solution. It's a positive ion, and the cell membrane is cholesterol based. It's lipophilic, and so it's like oil and water. So it doesn't get in. So what good is a bullet if it can't get to the target? So all hydroxychloroquine does, it opens a transport channel, or it's called a zinc ionophore, a canal that lets the zinc go from outside the cell to inside the cell where the virus is and that enzyme is. So think of hydroxychloroquine as a gun, and zinc is the bullet. And you need both in order to be effective. A bullet without a gun or a gun without a bullet doesn't work. So all these studies that use hydroxychloroquine and sick patients in the hospital, they come back, it doesn't work. It's not surprising.
Regarding these patients to whom you are telling, okay, your symptoms are not that severe, you go home, you isolate. Are you prescribing them something? For example, supplements or zinc, quercetin, and also are you asking them to monitor with an oximeter?
I actually lately have started to use quercetin more often, simply because in this country hydroxychloroquine has gotten such negative PR and demonization that it's become difficult sometimes to get. So quercetin, which is a natural supplement, has similar properties in one sense to hydroxychloroquine in that it's a zinc ionophore. So for prophylaxis, I've been giving it out very liberally with zinc. And for patients with mild symptoms, if they ask, or I even could mention it, but I don't mandate it. And I'll tell you why. My emphasis at this point has been strictly, let me define success, is to keep people alive, to keep them off a respirator, and to keep them out of the hospital. I haven't really done research or work on the low-risk patients, and if we give them the medications to shorten the course of the illness or the severity. It probably does do that, but I don't have that experience. I haven't focused on that, just because this is I've been dealing with the urgent catastrophe, pandemic, and my emphasis was to save as many people as possible. But I certainly hope there are people going to do research in the low-risk population to see if we can improve the course of even if they're not going to die, why should people be miserable unnecessarily? So if we can lessen the severity of the symptoms, that would be great. But I'm really not in the position to advocate that from any scientific perspective because of lack of experience and data. Although empirically and common sense-wise, on a case-by-case basis, I do recommend this to certain patients. But that's my answer.
Okay, so you don't tell them either to take vitamin C, D, these kind of supplements that are now quite widely recognized as being helpful from a prophylaxis viewpoint.
I do, but see, those are general preventive health issues, and I'm a primary care doctor.
Okay.
So I always check everyone for their nutritional status and try to make sure that all my patients are optimal when it comes to nutrition, and not wait until they get COVID-19 or any other illness to begin optimizing their immune system. That's a little late, actually. The time to make sure that someone is nutritionally, as good as they can be is when they come for preventive health visits. And You do the right testing, you make the right recommendations. So that's a standard of care for me. So
Okay.
it's not something specific to COVID-19, you understand?
Okay. And regarding the oxygen monitoring, are you doing something for those who basically wait for getting better? You know, the thing on the finger?
So, right, I know. I do that for a subset of patients that I'm treating. Those are that are, really high risk, and I'm not sending them to the hospital. So I do whatever I can to keep them out of the hospital, including home IV fluids, sometimes even IV antibiotics if people don't progress, and pulse oximetry, home oxygen. But that's rare because as I've started to be more aggressive and treat people earlier in stage 1, that becomes less and less of a necessity to supplement them with all these advanced measures. And I'll simply explain to you why. That the virus begins in the upper airway, in the nose and in the sinuses. When it's at that stage, it's really easy to clear. It's when it begins to descend down into the lower airway, that's when all the terrible complications begin. So my emphasis was always to destroy this virus while it's still in the upper airway. So the answer, it's a long answer, but for the patients that I do not treat, that are low risk and young and healthy, I just send them home and I have my office follow up with them. Close follow-up is much more important, in my opinion, than measuring some pulse ox. In other words, how you doing, how is your breathing, and any improvement, any change. If you're not getting better, or you come back, let me recheck you. I think that's much more fruitful, I would say.
Can you explain maybe briefly how yourself and your office proceed with receiving patients with suspected or COVID-19, in the sense that many doctors are afraid? I mean, many don't want to. They want to do telemedicine. You seem to see people. How are you doing to protect yourself, to protect the staff, and to treat people in a kind of a family doctor center, not in a hospital setting?
A good question. My particular case, if I speak about myself, it's a very complicated story because I'm immunocompromised myself. I had something called pulmonary artery sarcoma and had open heart surgery, and I lost my right lung. And I was on very difficult chemo, and I'm still on oral chemo for suppression. So if you think about any higher risk patient than me, it would be difficult to find because I have one lung, I'm immunocompromised, right? So how would what do I do? So initially, when there wasn't enough data, I had to capitulate to my wife and children, and I started practicing telemedicine because everyone was concerned for me, including my own doctors. But as the data started coming in and the effectiveness of using these medications in the right setting, and I've also started to do research on prophylaxis, which I don't have enough data yet to publish a study, but I can tell you amazing results. So I started prophylaxing myself. And I can just tell you that, I mean, maybe I shouldn't tell you, but I actually practice without a mask. I just, my confidence in the prophylactic ability of these drugs is so great that, I've been exposed to very high viral loads of COVID, and I feel really fine. So that's how I do it. But other physicians obviously follow their own comfort level. Many do see patients. We have, for the active COVID cases, we have like a sick room in a sense, or off-site trailer where patients are seen so that we don't bring them into the heart of the center to contaminate everyone. And some of the physicians come to see them, full gear. That's, that's their personal choice. And obviously, I would have to advocate to be conservative and would say for any primary care physician that they have to wear PPE, protective equipment. But I think that the data is really coming out to show that we should prophylax these people. And not only primary care doctors or nurses or frontline staff, but I would even say police and military and every nursing home resident. I found that in New York, at least where I am, some of the nursing homes had a 50% mortality rate. It was a bloodbath. So the higher the risk to the patient, the more I become aggressive in prophylaxing them.